great pleasure, please allow me to introduce you to Thurman Gillis Jr., our moderator for today's discussion. Thurman Gillis Jr. is a dedicated mental health counselor with a strong passion for guiding individuals of all ages through their mental health journeys. With over 16 years of experience in the field, he is the program director of the Coordinated Specialty Care, Community Integration, and Clinical High Risk for Psychosis programs at CarePlus New Jersey. He is also the co-founder and co-chair of the Inclusion, Diversity, Equity, and Action Committee at CarePlus New Jersey. This committee focuses on the issues surrounding diversity, equity, inclusion, and belonging, and how they affect clients, the community, and staff at CarePlus New Jersey. Thurman possesses a profound understanding of the interplay between mental health issues and diversity, equity, and inclusion. He is deeply committed to providing culturally aware and inclusive care for every adult, child, and family. Thank you, TJ, for moderating today on this important discussion, and I'll turn it over to you.
Thank you, Jen, for the warm welcome and introduction. And thank you all for joining us today for the topic that's so near and dear to a lot of our hearts that are in here. So today's panel, as Jen mentioned, is entitled Elevating Voices, Inspiring Reflection, Advocacy, and Change. So advocacy to raise the awareness and elevating voices to continue the crucial conversation around Black maternal health in conjunction with the integrated care process. It's been found that this is the most effective way in treating and supporting the whole person and the family over the course of the paternal period. So as we elevate Black women's voices and begin to advocate around these issues, we're seeking to drive change that would benefit all those affected. So 2024, Black Maternal Health Week's theme this year is Our Bodies Still Belong to Us, Reproductive Justice Now. It addresses the recent restrictions on abortion access and the criminalization of pregnancy loss. So our goal for today's discussion is to bring together individuals from various areas of expertise and disciplines who are very passionate and committed to the work necessary to elevate voices, raise awareness, and they do this by challenging and eliminating implicit bias that continues to plague our laws, our policies, our institutions, our providers, which in turn, these biases continue to silence voices and impact impact the access to significant care and that prevent inadequate care and unnecessary loss of our Black mothers and babies. So we're gearing up for a robust discussion, and we hope that you walk away today with some information and tools and tips that you can take with you for yourself in your everyday life, take back to your loved ones, or anyone who will listen to you, because some important stuff is going to be said here today. So this topic itself is very close to my heart because as a Black father, an uncle, and a son, and in many ways, like all of you, I've had to navigate disparities in my own health as well as the health of my family. I have a Black mother. I have 4 sisters who are all mothers to Black children. And most recently, I became a father to a son of my own. One thing that I would also like to mention here today is during our birthing process, when we were having my son and we were in the hospital, we had a doula, and we had a doula of color, and she was a mother herself of a Black child. Her expertise and guidance and advocacy during that process was absolutely invaluable to us. It made the whole experience more comfortable, like knowing that she was there and that she had our backs, and that, if anything was to go wrong or if something didn't seem right, she would speak up about it because she knew that whole world better than we did. This was our first kid, so we had no idea of a lot of things that was going on, but she knew, and she was there for us. She brought me Wendy's when I was starving, so that was A+ effort at least on that end, because I would have passed out if not. So anyway, enough about me. Without further ado, please allow me to introduce our amazing panel of experts for today's discussion. So our first panelist is Wanda Irving. Next up, we have Ladina Artist, and followed by Tanisha Sonneson and Dr. Azer Alizade, Dr. Kanika Harris. So Wanda Irving, MPA, is the forever mother of Dr. Shalon Irving, the co-founder of Dr. Shalon's Maternal Action Project, DSMAP for short, Incorporated. DSMAP is a community-driven nonprofit organization dedicated to alleviating Black maternal health disparities. The organization was established to honor Wanda's daughter, Dr. Shalon, who passed away from a preventable pregnancy complication in January 2017, 3 weeks after giving birth to her only child. Dr. Shalon was a brilliant researcher and fierce health equity champion. An effort to continue Dr. Shalon's legacy, Wanda co-founded the DSMAP, where she also serves as the president of the board of directors and acting president of the organization. Prior to establishing DSMAP, Wanda worked in various leadership roles in federal agencies, city organizations, and provided consultation services and technical assistance to nonprofits across the country. Wanda possesses years of experience in organizational development, community outreach, and has led numerous strategic initiatives and programs. Wanda is now fully dedicated to the mission of DSMAP and utilizes her keen expertise to enhance organizational resources such as Believe Her, an anonymous peer support app aimed to increase awareness of the Black maternal health crisis and promote evidence-based strategies that improve health outcomes for Black birthing people and families. Wanda is highly sought after and health equity advocate, appearing on national and influential media outlets such as NPR, MSNBC, GMA, Newsly, Revolt, and Health Affairs, a peer-reviewed healthcare journal, just to name a few. To date, Wanda has appeared before numerous organizations reaching tens of thousands with the goal of ending preventable Black maternal deaths in the United States. The work of DSMAP is based on the life mantra of Dr. Shalon Irving. I see inequity wherever it exists. I am not afraid to call it by name and work hard to eliminate it. I vow to create a better earth. At DSMAP, we honor Dr. Shalon's vow by working to remove barriers, biases, and despair practices that impede access to equitable, quality care for Black women and birthing people. Welcome, Wanda Irving. It's nice to have you with us. Next, we have Ladina Artist. Ladina Artist is a licensed clinical social worker and certified prenatal mental health. Prenatal mental health. Ladina is currently the Senior Director of Clinical Services and has been working for Care Plus for 24 years. And we are happy to have her. As an outpatient clinician, Ladina worked with a diverse population of individuals, couples, and families. Ladina has been trained and provided evidence-based screenings, assessments, and treatment interventions, specializing in working with those who have experienced traumatic life events, children and families in crisis, individuals and families faced with prenatal mood and anxiety disorders, individuals experiencing various levels of risk, suicidality, and self-harm behaviors, and various psychiatric diagnoses. distressful life circumstances and transitions, and unhealthy family dynamics. And her current administrative role, Ladina provides clinical oversight for outpatient programs, including the more specialized programs, the Maternal Family Center and the Dialectical Behavioral Health Therapy Program. Ladina has provided staff trainings on cultural humility and implicit bias with the goal of working toward instilling the importance of creating a more inclusive, culturally congruent work environment for employees, as with as well as diverse populations served by the agency. The range of expertise over the years has contributed to Ladina's person-centered approach with the focus on developing a team who meets people where they are and have the clinical skill set to carry out interventions based on individual and family needs, and that promotes risk reduction and client safety, client determination, and successfully identified treatment goals. Welcome, Ladina. It's nice to have you with us. Thank you. Next, we have Tanisha Isanasen. Tanisha is a marriage and family therapist, sex and wellness educator, and advocate. She earned her bachelor's of science degrees in Black Studies and Psychology from Lincoln University and PA, and holds a Master's of Arts degree in Marriage and Family Therapy from North Central University. Tanisha spent 17 years as a community health professional working with women, children, young adults, and families to bring awareness and access to resources that sustain whole life well-being. These experiences helped her develop a specific vision for empowering women and their families toward generational health. Most recently, Tanisha is collaborating with women, couples, and families as a marriage and family therapist at the Black Women's Wellness Company. Her work centers destigmatization of mental and emotional health for women experiencing anxiety, depression, and post-traumatic stress. Tanisha's work also focuses on offering clients accessible daily life practices that liberate them from impoverishing social conditions. Tanisha is passionate about cultivating equity in communities impacted by a history of colonization, human trafficking, and racialized capitalism. She identifies these experiences as an ongoing global harm to humanity's story. Tanisha believes that health begins in the stories that we tell ourselves and is committed to supporting women and telling their stories with truth, power, and dignity. Welcome, Tanisha. And next we have Dr. Azer Alizade. Dr. Alizade is a board-certified obstetrician and gynecologist with All Health OBGYN and Wellness, and is affiliated with multiple hospitals in the area, including Hackensack University Medical Center and Hackensack Meridian Health and Palisades Medical Center and Hackensack Meridian Health. He received his medical degree from IM Moscow Medical Academy and has been in practice for more than 20 years. Dr. Alizade is dedicated to providing women with the highest level of gynecological care, including a wide range of services from preconception to routine prenatal care to care of complicated high-risk pregnancies. As a leader in the minimally invasive gynecological surgery, Dr. Alizade specializes in laparoscopic, hysterectomy, and Da Vinci surgical procedures, such as Da Vinci hysterectomy de Vinci mycotomy, as well as pelvic floor reconstruction and urinary and continence surgery. Thank you, Dr. Alizade, for being with us, who is not currently here at the moment, but we do have Dr. Ahmad sitting in his place for now. So welcome and thank you for being with us until Dr. Alizade gets here. Next, we have Dr. Kanika Harris. Dr. Kanika Harris currently serves as the Director of Maternal and Child Health for Black Women's Health Imperative. She is a behavioral health scientist with special focus on health equity, maternal health, and women's health. She is the mother of 3 and a near-miss survivor, a doula, and a birth justice advocate. She also serves as a maternal health equity advisor for the state of Maryland and the public health expert for District of Columbia's Mayor Commission on Lactation. Dr. Harris is co-directing and producing a documentary called Listen to Me, which explores 4 women at the front lines of Black maternal health, at the Black maternal health movement, walking the tightrope of racism and birth in America. Funded by Black Public Media, she received her master's degree in public health and international development from Morehouse School of Medicine and her doctorate in health behavior and health education from the University of Michigan. Thank you, Dr. Harris, for being with us. Those are all of our panelists that will be with us today. So welcome to you all again, and thank you for being here. We're gonna get underway with our questions. First up, we have questions for Wanda. Wanda, we understand that the motivation for the work that you do through Dr. Shalon's maternal health project was inspired by a very personal experience. Would you mind sharing a bit about that experience with your daughter?
Certainly. Thank you very much for the question, Thurman. And remind me to make sure that my EA trims that bio down. My daughter, Dr. Shalon Irving, was an amazing woman. She was, she had dual PhD in sociology and gerontology, 2 master's degrees. She was a lieutenant commander in the U.S. Public Health Service, and she worked diligently as a well-respected epidemiologist at the CDC. She used her voice to fight for health equity by exposing hidden gaps in public health. She intuitively saw structures, systems of relationships, and social dimensions of public health problems that went unnoticed by so many others. She used her unique vision, her in-depth understanding of intersectionality to call attention to situations unseen, to life experiences undescribed, and to struggles unwitnessed. She was, she helped shed light on many complex issues in nuanced and thoughtful ways. But in 2017, my dear daughter fell victim to the same health inequities she fought so hard to eliminate. She was the type of person that would do anything for anyone. She was very, very morally bound by her own beliefs. She had been so excited to find out she was going to be a mother, and that it just put her over the moon. She did everything right. She went to all of her appointments. She exercised. She ran in marathons. She did everything she was supposed to do, and gave birth to my only grandchild, a daughter that she wanted so desperately to have. And she named her Soleil because she said this child was the sunshine of her life. But 1 week after giving birth, she started having complications. She knew there was something wrong, and she went back and forth to her healthcare providers no fewer than 5 times during those 2 weeks leading up to her death. Each and every time she was sent home with sort of a pat on the head with, things will get better, give it time, you just had a baby. Even though she was presenting with really high blood pressure, she had swollen limbs, she was not voiding, she didn't feel well, she was experiencing headaches, and still they kept sending her home. I'll never forget the last visit when she went in. She had gained 9 pounds in 5 days. She had a swollen left leg that was at least twice the size of the right leg. Yet and still, she asked to see the doctor. She begged to see the doctor. And the nurse took her blood pressure and took it twice because she couldn't understand why it was so high. I thought maybe something was wrong with the machine. But she asked over and over, I need to see the doctor. The nurse left her in there for 20 minutes, 25 minutes with a newborn baby, pretty much, and came back with a prescription and not the doctor, and said, well, the doctor's too busy to see you, but here's a prescription for medication. And if you don't feel well in a couple more days, then come back in and we'll see if we can set up an appointment with the doctor. My daughter had about 7 more hours after that before she collapsed and never regained consciousness. So that is the main reason why I do what I do. And I blame systemic racism, which is rampant in this country. The resulting implicit bias allowed her healthcare providers to dismiss, disrespect, and devalue her life. And the implicit stereotyping and prejudice caused her pleas for help to fall on deaf ears.
Thank you. Thank you for sharing, and I'm sorry for your loss. You mentioned a bit about systemic racism and implicit bias and how that played a role. Was there anything else that you wanted to add that you feel kind of affected your daughter's whole situation in regards to that?
I think the bottom line is the racism that runs rampant, and especially in healthcare. Because in my mind, a woman of her educational background, professional standings, the fact that she took her health very, very seriously, and she knew to come in and see a doctor, and to have that woman sent home time and time again, it doesn't resonate to me as anything other than racism. Had she been of a different hue, she would have immediately been put into the hospital. There was no indication that any of her symptoms were taken seriously. She had gold-plated insurance. She worked at the CDC. She knew health. What would have been the harm in putting her in the hospital, even just to monitor her for a day, 24 hours? And she would have been here today, I believe.
Yeah, thank you again for sharing. Okay, so can you expand a bit on the 4 pillars you base your actions and strategic partnerships around? So the storytelling, empowerment, community building, education.
Yes, those are the tenets that we do all of the work that we do around. Storytelling, we think, is probably the most effective way to advocate for change, because people better understand what is going on and why. I apologize, I thought I had put it on airplane mode. I'm sorry. Okay.
All right.
People better understand if they are exposed to situations from a personal point of view. It's a lot easier to identify than just reading it. So that is one of our main tenets. We believe in empowering women to speak up for themselves, but we also believe that empowerment has to go to more than just women. We don't believe in victim blaming and expecting the woman to do everything, especially after having a newborn baby. So we want to empower the spouses, the partners, the family, the grandmothers, et cetera, whoever can be an advocate for that woman. We believe that the community has a part in this. And we're now reaching out to churches and trying to bring this kind of training, education, awareness to the faith-based sector as well. And in community building, we work very diligently with quite a few different organizations that are in this field, because we believe that well, not only the two heads are better than one, but the whole collective impact of organizations working together is what's going to change, because not one organization is going to make a difference in this. No one person is going to change this. We've all got to work together in order to make the kinds of changes that need to happen.
Absolutely. That's definitely some deep and involved things that you're doing there. And each of those aspects are important in their own way, for sure. And I can see how bringing those together would definitely build. So what are some of the changes that you have inspired or witnessed as a result of the work that you do through the nonprofit?
Well, we have, I think, quite a few. We feel very, very proud in what we've done. The Believe Her app is one of those. We are also improving the Believe Her app, which we launched in 2021, but we're adding a digital community to it. We're making it free. We're allowing training and education to go on in the app. So we're really proud of that. We're working on launching our Grandmothers Rallying Against Maternal Mortality project, which is GRAMS. And that provides a network for grandmothers like myself to find answers and to find community while redirecting our grief into action. I'm working with a national collective that produces the annual Speak, Move, Change events. We've done that for 3 years in a row, and I think our last one was the most powerful ever. We put J. Marion Sims on trial, and Mobunji, and it was amazing. We are also working on a National Postpartum Week, which is coming up May 4th through the 11th. And we'll be doing a couple of panels also on that with several different topics, but mostly physiological and social. And I'm proud of the work that we're engaged in with Dr. Natalie Hernandez at the Morehouse School of Medicine. We're working with her on the Near Miss Project as we're seeking answers to preventing those near fatal experiences for Black women. We're also working with Safer Birth and Sutter Health to build accountability training for physicians and clinicians. And what we've designed so far, I promise you, is trailblazing. We're excited about the research we've got planned with GEHA. We're working with them on assessment project right now on the unmet needs of Black women in the military. And we have a couple of other research projects that will get underway later. So we really believe in collective action. We really believe in working together with organizations. And DSMAP stands behind Shalon's mantra, and we take it very, very personally.
I say it sounds like you're giving that voice to the voiceless, right? Uplifting voices and making sure they're heard. Thank you very much for that work. So we're aware that addressing health disparities to give mothers the support they need before, during, and after pregnancy, as well as the provision of safe maternal health care for Black women is pivotal in the fight for reproductive justice, as equity and maternal health care must exist in order to achieve reproductive justice. With that being said, what are your thoughts on the current efforts being made to make real sustainable change in this area, and what areas still need the most urgent attention and action right now?
I would say there are two areas that I see that need the most urgent attention. One, policy and
Mhm.
law. We have got to build accountability into the hospital systems, into physicians, mantras, whatever. We have got to make that, I don't know if it's a carrot or the stick or whatever it is, but we've got to make them accountable. We know that, like in the, what are they? The maternal, the councils that review morbidity review committees, I think, they can see that one doctor been, may have attributed to his name 5 or 6 different deaths, but his name is never mentioned. Maybe the hospital might be mentioned, but that is not good enough. We need to call them out and say, look, there's something wrong here. If women are dying under your care, we need to move you out the way because we can't have that going on. So we have to have laws that are put in place. Congresswoman Underwood has done tremendous work in the field with the Omnibus Act, et cetera. She was a really dear friend of Shalon's. And she'll tell you, she even started down that road because she lost her dear friend. That has not passed. There are pieces of it that have. Why can't we get that over the finish line? The second thing would be more formal educational medical training for students coming out of medical or coming through the medical schools. There are a lot of students who are still coming out with the same stereotypes that existed when J. Marion Sims was practicing his atrocious medical practices on slave women. And they're coming out with that same mentality that Black women, they can withstand more pain. Our bodies are different. Our skin is tougher, all of that. And that is what is bringing these doctors to a place where they can disrespect us and disvalue our lives. And until those things change, we're going to be in the same situation. Nothing is going to move that needle forward.
Yeah, absolutely. Very powerful. And it's as much work as, continues to be done. There's always more work to be done. Right.
Absolutely. And we have got to call it as it is. If
Yep.
it's racism, then let's call it
Let's call
racism.
it. Hmm.
And let's do what we have to do to get rid of it.
Yep. Yeah. I find the tiptoeing, right? I feel that people tiptoe around certain words that hold this power. And the more we tiptoe around these words, right, the more power they hold.
Absolutely right.
Hmm. And thank you very much for that. Uh, so in your work and experience, can you speak about how children and families are affected by the loss of mothers during pregnancy-related illnesses?
Oh boy, that's a big one. And I can definitely speak to that. My granddaughter is 7 years old now. She knew her mother for 3 weeks. I have tried my best to instill in her stories, memories, and exposed her to people who knew her mother, and they've shared with her. So she has I guess this connection to her mother, even though, like I said, she's only known her for 3 weeks. She can tell you her mother's likes, dislikes. She's so much like her mother. But there are times, you know, it wasn't easy getting to this point, which is why we're doing Grams, because I didn't know how difficult it would be to raise a child in these times. My children were born 40, 50 years ago. I didn't understand what was needed to raise a child whose mother died as a result of maternal mortality.
Mhm.
There were so many times that she would just just get so angry. And it's like, what is wrong? And it was the pain of not having her mommy. And she'd cry uncontrollably. she still does that to a certain extent now. I have her in therapy because we're trying to work through some of those issues. She still at night wants her mommy to tuck her in. And even though she has pictures of her mom all around her bed, you know, and her mother with an angel wings, her mommy is, you know, an angel. She's right there. She's with you. She wants her mommy because she goes to school. Her friends have mothers. She doesn't. And they ask her, why isn't your mommy here? What do you mean she's dead? What does that mean? Where is she? And she has to deal with all of that on a daily basis. People don't realize, especially scientists who are going through the numbers, and it's like, oh, well, it's only one woman. No, it's not. It's that woman, it's her parents, it's her spouse, it's her cousins, it's her whole family, it's her community, it's her church. All of those people are affected. And we don't recognize, we don't appreciate the domino effect of that. And in the research that I've read, it says that that trauma that these kids endure exists in up to 7 generations. That should scare folks to death because 7 generations out are going to be dealing with that. And those are the generations that are going to be running this world. And until we come to grips with that fact that maternal mortality is more than just one woman, we're going to be in a pretty sad shape.
Absolutely, though. I definitely very, very powerful. And you raise a good point of being in the position of needing to raise a young child, and have the last time you did it was a while ago. It was a long time ago, and there's a lot of families in that same kind of situation, right, where they kind of have to relearn all these things all over again. So thank you very much for sharing. Appreciate it. And thank you for being with us. Thank you for being here.
Thank you for having me.
Thank you. So we're gonna pivot to Ladina, and we have some questions for you, Miss Ladina. Can you tell us about the services that you provide through Care Plus Maternal and Family Center?
Absolutely. Well, first, good morning, all, and thank you, TJ, for being our moderator today. And I also wanted to briefly speak to Wanda, and how much I appreciate you showing up in this space, in a vulnerable and authentic way, in sharing your story, your daughter's story, your family's story. I, for one, appreciate that so much. And I'm sure that your granddaughter is going to appreciate the way that you're honoring her mother. Absolutely. And her mother's legacy, and keeping her voice elevated in all that you do. So again, thank you so much. I don't know how to follow up on that, but I will do my best in this space. So to answer your question, Thurman, the work that we do in the Maternal and Family Center here at Care Plus, the purpose of that work is to meet the maternal mental health care needs of women, birthing people, partners, and families during that antenatal period, which is before pregnancy, prenatal period, which is during pregnancy, and up to 2 years postpartum. Our specialty care is provided with the expertise in treating the whole family. So you heard Wanda mention that it's not just the one woman or birthing person. It is the family who can be impacted in many ways, whether it's physical or mental health. So it's very important to acknowledge that the impact on everyone involved. The services that we provide are tailored to fit the individual needs of women again, birthing people, partners, and the families that we serve. Our team of providers are specially trained in perinatal mental health and are certified through Postpartum Support International. Some of our goals as a mental health provider is to improve the ability to cope and function during this perinatal period, to also increase awareness and access to treatment, prevent adverse outcomes before, during, and after treatment, to also promote integrated physical and mental health care. This is something that CarePlus New Jersey as an agency has been committed to. So committed to the treatment of the whole person and the family. So coming from more of a holistic perspective is extremely important. And with that being said, we stress the importance of a continuum of care. So that includes the screening, comprehensive assessment to identify the needs of the individual and family, provision of treatment, as well as consultation, training, and education. And that includes, reaching out to all entities and providers and collaborating with them based on the needs of the person and the family. And also, of course, providing resources and referrals to ensure that we're addressing as many of the needs and concerns and barriers that may come up over the course of treatment.
Absolutely. Thank you, Ladina. I know you mentioned the integrated care approach, and I'm wondering what impact do you think that has on the success of the clients?
Of course. So when I speak to integrated care, it involves consistent collaboration between all healthcare providers, supportive services, the individual in treatment, as well as the family, the caregivers, in order to develop a comprehensive plan of care, right, as related to the identified needs.
Mm-hmm.
And again, I stress the importance of treating mothers, birthing persons, and families from a holistic perspective. The Maternal and Family Center team does recognize that there's a need for that multidisciplinary integrated approach to treatment in order to promote and support the successful outcomes when working with this population, and recognizing that there's a multi-level and at times complex needs that need to be addressed. So we're not only providing psychotherapy and medication management, which is great and effective, but our team, again, is often collaborating with all providers and entities, case managers, peer supports, community outreach teams, primary care physicians, community and hospital-based OBGYN providers, social services, external mental health providers, community advocacy groups, legal services are at times necessary. So again, just embracing the importance of addressing needs from a holistic perspective, I think is the basis for that integrated care approach.
Right, absolutely. Thank you for that. From your perspective, what might improve the access to care for Black and people of color mothers and birthing people look like? Like what does that look like to improve that access?
So as Wanda also spoke to, and as we know, the history of systemic racism and implicit bias has greatly impacted the inequities and disparities that we continue to experience. While we're having these conversations, and there is action being taken, there is advocacy, there is so much more. that we need to do collectively. As you know, we still experience those negative and stigmatizing attitudes toward BIPOC groups, you know, and with implicit bias, you know, it is held at a subconscious level and, you know, can automatically activate during a provider, mother, birthing person, family encounter. And that implicit bias can impede the access to care. Of course, it can impact the clinical screening and diagnosis, the treatment processes, as well as how to respond in a crisis. You know, so so the absence of, you know, going beyond the clinical history gathering often leads to those generalizations, stereotyping, misdiagnosis, you know, just general misunderstanding and oversight of specific cultural factors that may be contributing to the presenting symptoms, which essentially, you know, results in a mistrust in the healthcare systems, right? Policies, providers, as well as underutilization of healthcare services and especially mental health services. So I felt I had to state that before going into, you know, the importance of developing a truly inclusive, and I say truly, authentically inclusive anti-racist systems with policies, practices, and procedures that promote racial equity, health equity, and quality care for everyone, where people are just treated with a level of respect. That's where it starts, right? Cultural humility, just a level of respect, valuing their voice, letting them know that they're heard, where they are provided with, you know, the opportunity to show up as their authentic self and not feel devalued, not feel unheard, right? Reducing stigma, shame, and guilt related to admitting that there may be a problem, and then, you know, seeking and following through with treatment. So that empowerment of Black and BIPOC mothers and birthing people, again, to utilize their voices, increasing Black and BIPOC maternal mental health and healthcare providers, increasing awareness, again, of implicit bias, incorporating cultural humility into clinical and healthcare practices. And when I say incorporating it, it means, you know, taking an active stance, right? So not just learning it and understanding it, but actively and intentionally incorporating it into your practice.
Absolutely. I mean, again, these are all things that need to be addressed and we need to speak about, right? And one of the biggest purposes of having discussions like this is to move change forward, right? To do things differently. In order to do things differently, we got to know what the issues are, right? And unfortunately, just us knowing the issues is not the resolution, right? Things need to actually be done. So thank you very much for that, Ladina. So as a prenatal mental health provider, can you speak to specific experiences, professional or personal, that you considered significantly impact or contributed to your passion for working with the population?
Sure. So where do I start? So just so many experiences, but I guess I'll start from, you know, a more personal, you know, perspective. You know, I show up in this space as a Black woman, So recognizing firsthand, right, how systemic racism, implicit bias, affects us, on a daily basis in many spaces and various aspects of our life. So when they talk about chronic stress, I recognize that as a Black woman, as a mother of two Black sons, raising two Black sons in this society, one of which has a significant disability, so that is one in terms of the personal. In terms of professional, again, so many experiences, but just being in a space with women and families who have been just largely impacted by intergenerational trauma, you know, being silenced, not only by the systems, but sometimes within their own family dynamic, right? The expectation, right, that you are the strong one and you uphold, right, everything and everyone, right, and in having all of that to bear, and then going through the process of sometimes just getting pregnant, and then pregnancy, and then postpartum, and at times not feeling like they can speak up, not feeling like they can have a voice or should have a voice out of fear at times, right? I think that has been extremely impactful, because when I show up with them in that space, right, I want to provide that space for them to be able to show up again as their authentic selves, and also to recognize that what they're experiencing does not take away from who they are, their roles in society and within their family. It is essential, for them to prioritize themselves, and to identify what those needs are and reach out for support. It is absolutely okay. It does not take away from your strengths. That does not take away from, who you are and how you identify. So I think that, and I hope that answers your question, but that is what has been extremely impactful for me, and why I continue to show up in as a clinician, in these spaces, because it's just so important to continue to have these conversations.
Absolutely. Thank you, Ladina, for bringing that authenticity to this space. We appreciate it. And thank you for your time being on this panel.
Thank you.
So being cognizant and honoring your time, Dr. Harris, we are going to go to you next, if that's okay.
Absolutely. Thank you.
Excellent, no problem. So if we're going to address maternal mortality and disparities, no matter what the disparity is, we must address the implicit bias and systemic racism, which we've spoken about a little already this morning. It's not just the providers and the hospitals that need to make the change, but social, political, and research communities. Can you share some of your thoughts on that, and how does that change happen? How do you think that change will happen?
I think, first of all, thank you for inviting me, for being here. As always, I want to lift up Shalon Irving and the Irving family and Soleil. I hope everyone on this call can just take in the the gravity of what Miss Wanda is sharing in terms of her sharing. Every time she shares her story, I just recognize that she's making the ultimate sacrifice for us to solve this problem. The amount of grief and pain that you experience retelling your story is beyond invaluable to solve this problem. So I just want us to always keep that in mind and hold that these stories, for everyone who decides to share their story, it has a profound impact on, their grieving process as well and how they move through things. So we are deeply, deeply, we can't thank you enough for your work and for how you've upheld Shalon in the highest light for, many, many years now. So to answer your question, as a society, I don't think we recognize that we measure the health of a society by our birth outcomes, right? And by our maternal and infant mortality. So just right there as a nation, we're headed in the wrong direction. We are a very sick nation. And I think in order to solve these problems from a systemic level, um, there's going to have to be a lot of things that happen. Like there's going to have to be some shifts in power. There's going to have to be some recognition, some recognizing that the current maternal health system does not work. And when you're saying something doesn't work, that means some things have to go, some things have to change. And people don't want to make that sacrifice and that change. I think also what it looks like is if our nation is sick, every facet of society is going to have to work together to solve this problem. So that means that um, if you heard the many, many things that Miss Wanda is doing as one mother and one individual, and she knows that this is not going to solve the issues. It means that all of the many facets of our society, from, transportation um, to, food to education, all of these facets of society are going to have to take up their work in maternal health and take it up as an issue in order for us to solve it. We can't keep running to every social determinant of health ourselves to make you recognize that you need to take up this issue as well and how this issue is affecting us. Um, you know, Systemic, I saw for the first time, I'm really excited. I didn't read it yet, but the Robert Wood Johnson Foundation put out a document for the case of reparations. So if we're talking about systemic racism and we're talking about how to solve it, and we're talking about shifting power dynamics, we have to get down to the root because we know that maternal health is not just in the perinatal period. It's not just having babies. It is from the time you are born, right? The time you are born, that affects your chances of having a good birth outcome and a healthy baby from the time you're born. Your experiences lead up to that experience. Are you going to have the choice to pick the kind of birth that you want to pick based on your health walking into pregnancy? And then when you have that baby, how are you walking out of pregnancy? What does your health look like after your baby? What does your health look like postpartum? And that's setting you up for the rest of your life. So maternal health is literally our entire life course. And so when we look at that, what are the things that we need as Black people in this country that are experiencing the brunt of this issue? The World Health Organization has called it a violation of human rights. The World Health Organization has called maternal health in this country as a violation of human rights, specifically speaking to the inequities of Black and brown people. So in order to do that, we have to look at the full spectrum of the impact of racism on this country and how it affects our ability to get pregnant, have healthy birth outcomes, survive after pregnancy, and also thrive after pregnancy.
Absolutely. All powerful words being said. And with understanding that and having that understanding, what the work that you do through the Black Women's Health Imperative, how do you feel it addresses the Black maternal health crisis?
And my little efforts um, to put a dent in this, I've decided to focus on well, I focus in a few areas, but one that I saw just multiple ways of affecting this issue is through a pilot program that I started on HBCU campuses called Nourish, which stands for New Opportunities to Uncover Our Spirit, Intuition, and Healing. Intuition, Spirit, and Healing. It's a, acronym. With that program, what we've been able to do is train nurses, medical students, college students to become full spectrum doulas. But in doing that, we also provided them with preconception health coaching. We partnered them with Black OBGYNs to make sure they understood their numbers and their reproductive health status as a marker of one day you're going to be pregnant, and we don't want you to walk into pregnancy not knowing your numbers. A lot of Black students on college campuses are already pre-diabetic, pre-hypertensive. They don't know their numbers. And we're hearing over and over again that doctors, it's like a watch and wait situation when you already walk into pregnancy sick and they didn't know. And maybe it's the first time you got reproductive care in a long time. So we wanted to address the preconception health journeys as a two-pronged approach of them becoming peer counselors on campus, them understanding where they are, getting health coaching, going through a full spectrum doula program, which allows them, one, for themselves to know what they're walking in with pregnancy, but two, to also increase that perinatal workforce that is a part of the Momnibus Bill in action. And then also through that, we are also helping with the next scholars of maternal health leaders. We know our HBCU campuses are literally divested in. So knowing that midwives are also a missing link in saving lives in this situation. We've already made the case for midwives and doulas. This is an international case. This is not just US. The entire world is saying that midwives and doulas save lives. So knowing that our HBCUs are not set up to train the next generation of midwives, the next generation of maternal health researchers, on this journey, I've learned that, in order to have a maternal health program, you need a school of public health. Many of our HBCUs don't have schools of public health. I don't know if any, maybe one has a school of public health. None of our HBCUs right now have practicing midwifery programs. We have a few, of course, that are turning out doctors and OBs, but we need a multifaceted approach to the healthcare providers that are solving this issue. So that's one way that I've wanted to address multifaceted issues, and making sure that our young women are walking into pregnancy knowledgeable and knowing, and that they can spread this information to their peers in college and to their communities. We actually had one young woman in college give birth in our program. She did have preeclampsia, and but we were able to surround her with the knowledge and the support and the love and the advocacy to come to the other side. Okay, we're mom and baby, we're still healthy. So those are the kinds of things that we're trying to do. We also do research in maternal mental health, working on changing the scales that don't capture the experiences of Black and brown mothers in the postpartum process. You know, the Edinburgh scale was not tested on Black and brown people, or that wasn't used in our research. And so how are we developing scales that address and capture the perinatal mental health experiences of Black and brown women and birthing people postpartum so they can get the help that they need. And the last thing is that we realize nurses spend most of their time with perinatal patients, birthing people, like, you know, a lot of times OBs coming in at the end to catch the baby, but it's the nurse that's been there 90% of the time. So we wanted to make sure with this case that America has now made on racism in nursing, that we address the inequities within the nursing profession. And when I say racism, it's one thing for that implicit bias, as we talked about before, in nursing to be passed from nurse to patient, but we also recognize the incivility in the nursing profession that doesn't allow Black nurses to have the autonomy and also be respected to support their patients. So we found that Black nurses are also experiencing harm to be able to provide the necessary care to their patients. So it's one thing when your patient is not listened to, but it's another thing when your nurse doesn't have the power and the autonomy to help you either, because no one's listening to her either. And so those are the main three buckets of work that we're doing at the Black Women's Health Imperative and maternal health.
Wow, I mean, you describe it as the little bit that you're doing, but in reality, that's a lot. It may feel like a little bit, but being that, you know, the severity of what we're dealing with, but that's a lot. Can you just speak a little bit about some of the resources some of the doula resources that are available to women and families in New Jersey?
That's a hard question because I'm national, but I am not as well versed in New Jersey per se. I can speak on a national level. You know, I think so what I would say, this is my best answer to this question. And Ladina, if you want to jump in, I'm happy for you to jump in and help me with this. But I can say if you're looking for doula services and doula support services, um, we're at a point, and I'm pretty sure New Jersey also has Medicaid reimbursement now for doulas. And so I would look at the list of Medicaid reimbursement training programs where who's on the list for Medicaid reimbursement in New Jersey. And I'm also following the work that's happening in New Jersey. I also feel that there are organizations that focus on communities of color that have made that list. So I would look at that list. I believe Ancient Song is on that list, which is a wonderful organization that supports families of color and has a very amazing comprehensive program, as well as many other programs. And so I would look on that list and pick out a doula service, interview them, and figure out which one works for you.
Okay, thank you very much for that.
Does that work? That works? Okay. Okay.
Yeah, that gives more resources than we had going into it. So just lastly, can you tell us a little bit about your work in co-directing and producing a documentary called Listen to Me, which explores 4 women at the front lines of Black maternal health movement, walking the tightrope of racism and birth in America, funded by the Black Public Media.
Yes. So Listen to Me actually started in 2018. the journey started in 2017, um, when I heard of Shalon's passing. Shalon and I were actually pregnant at the same time. We had a mutual, very close friend, um, who was one of Shalon's mentors and co-workers at the CDC. We were supposed to be connected, and the three of us were kind of experiencing pregnancy at the same time. For me, my second, I guess my third pregnancy, actually. And so hearing Shalon's story, recognizing that that could have easily been me. My story was almost textbook similar to Shalon's. The only difference between me and Shalon is that I actually had a doctor, a friend, a close friend I went to high school with, that was a white male, that was a resident at the hospital I delivered. And when I was sent home 2 times, and with no response, with doctors just, calling me back on the phone or not listening to me, I finally called him and I was like, these are my symptoms. I think something's wrong. And he came to my house, he picked me up and he wheelchaired me into the hospital and said, "You will see her right now." When they took my blood pressure, it was almost stroke level. And like I was whisked away right away. And then like the level of care that I needed after that was super complicated based on waiting. And so listening that it took a white man that was just a resident at the hospital, had I not thought to call him, I don't think I would be here as well. So knowing Shalon's story, knowing my story, and then many stories just in our circle, um, we just wanted to show just a level of storytelling and intimacy, for Black women to understand what's going on, to understand what happens in our body and why it happens. That, as Ms. Wanda said, we do everything right, that it's not our fault. But we also wanted to show a level of hope and healing. So, for example, when I met with Miss Wanda, she was in a state of like, I would say at that time, a victim state of, I don't know why this is happening. I don't know what to do. I don't know how to continue my life. That's the state where I met Miss Wanda. We were all rallying around her, trying to support her. But now Miss Wanda, as you heard, is like a renowned speaker and advocate on maternal health and mortality. So we wanted to follow the journeys of how we get to the other side. And while she's carrying this immense grief, um, you know, she's also a powerhouse. She's also moved to change. And so we hope to finish the documentary in the summer. We've watched Soleil grow in the documentary. We've watched Miss Wanda make some of her dreams come true. We've watched Miss Wanda go from, I don't know how to raise this little baby, to Soleil being like this genius child, a piano player, karate, all the things. And so that's a part of it. Like we don't want to leave these stories in a state of victimization and grief. I could have done a very quick documentary and just had a few videos on Miss Irving at that moment in time. But it's taken us so long to finish because we do grow and move past these situations. I don't think we ever move past the heartbreak and the grief, but we do move to change and hope as well, and we can hope both together. So I thought it was important that we show the biology, we show how these things happen, we show that it's not our fault, we show the impact that it has on family and communities, but we also show the healing, the hope, and the victories behind what happened as well, that we don't leave our stories in a state of like just immense victimization and grief. And so that's what I am doing with Listen to Me. Yeah, so it's been a journey of following stories over the past 7 years.
All right, thank you. The documentary sounds amazing. I know we do have a short clip here to show everyone. So we're going to cue that up and get that ready to show.
I think the Black maternal health movement is very, very old. And it began on the journey here when Black women made the decisions to throw their babies overboard rather than have them being born to us to wherever they didn't know they were going or what was going to happen to them. But they intuitively knew that it was not a good thing.
If you ask me from a non-scientific medical place, I completely blame my infertility on years of night call, years of chronic stress, and predominantly white institutions.
I'd never been pregnant before, so being pregnant with twins was tough.
Shalon had a huge village, and they all were so loving of Shalon.
I didn't know what pregnancy felt like. Blood pressure was fine, everything looked good. Went to sleep, but this headache just would not go away.
She told them the symptoms, she expressed them very clearly. 3, 4, 5 visits, and nothing was done.
Where else do you go? Like, who else is out there to listen to your pain and to what you're dealing with?
I've done everything, like acupuncture, Chinese medicine. So tired of the supplements. I'm so tired of the appointments. I can't wait to let go of all of that.
Do everything right, you have the resources, you have the knowledge, but it still is not enough to save you. Then what's the answer?
Wow. That's going to be very powerful. Very powerful. Thank you, Dr. Harris,
Thank you so much.
sharing with us. Thank you for being here. Thank you for the work that you are doing.
And I want to thank, I have to also always give a special thanks to Miss Wanda for trusting us with her story.
Absolutely.
We take it very, very seriously, how we capture and hold her family and her daughter's legacy. So I trust her she's been on a very long journey with us. So I just want to thank her for, allowing us to also shed a different light on Shalon's story and legacy as well.
Absolutely. Thank you.
And I have to apologize. I have to run. I'm in Oakland, California, but I live in Washington, D.C. I was here for Black Maternal Health event, and I'm learning that there's more traffic than I could ever imagine in California. And I need to run and catch this flight. But I thank you all. I'm sorry I'm not going to be here for discussion, but I really appreciate your time. I'm not sure if you have more questions for me, but I can stay a few more minutes.
No, that was all. Thank you for being here again. And, we don't want you to miss your flight.
Yeah, it was an honor to be in conversation with you all.
Yes.
Thank you so much.
Thank you.
Thank you.
All right. Next up, we have Tanisha. So, what are some of your thoughts on the importance of developing a workforce that is culturally competent and sensitive to the needs of Black women and birthing people's experience?
Well, first, thank you, TJ, for moderating, for you all inviting me to participate in today's discussion. But to speak directly to what you're asking, I had the honor of partnering with Miss Ladina Artis some years ago in developing the cultural humility and implicit bias training for mental health professionals. And when I think about the process of developing that training, and just doing diversity, equity, inclusion work for mental health professionals, but for providers who are entrusted in having an expertise. The outcome of that, I don't think, is what folks may be expecting for me to say. I actually became a little disheartened in what has become of diversity, equity, inclusion work, and I champion the warriors that have continued moving forward. But I've learned in my work beyond that training with Ladina to prioritize the safety of Black women, and what that looks like, particularly Black women who are birthing, is having care teams, having providers that look like you, that trust the intuitive expertise that you hold, and that have humility around the deficits of their own training, that some of their training is rooted in the brutalization of Black women in their bodies. And so developing a workforce, my beliefs around that is to prioritize funding, to prioritize policy that gets more Black and BIPOC providers into those spaces. I believe it's really important when I think about being a mental health provider myself, the relief that many of the women that I work with feel in being able, as Ladina said, to show up authentically. So that has to be the priority. That's my belief. It has to be the priority that we get more Black, more brown, more BIPOC providers into the field, because there is an inherent ability to connect to the humanity, to empathize with people who look like you. It's a part of the process for individuals who are consuming medical care, who are consuming treatment, to experience that relief of having a provider who they can entrust their care to, that they will be seen as human, that their own knowledge will be honored. So that's my priority. I do think that there's still, as a secondary priority, DEI training has to, be continued. It has to be provided for individuals that are coming out of medical school. It has to be the work that Dr. Harris is doing at HBCUs as a graduate of the first HBCU, Lincoln University, who has a phenomenal nursing program. I know how critical it is that education like that happens on those campuses, that doula training, midwifery, right? And I have so many thoughts about midwifery. I'll get into that at a later time, but it also has to happen on at PWIs, predominantly white institutions of education. That training has to be embedded not just as a course, but as a through line to all courses, all training. That there has to, number one, be an awareness that there is an inherent dehumanization of Black consumers of treatment. And that is embedded in the very fabric and the policy of these here United States of America, that everything has been touched by racism. Everything has been touched by the dehumanization of Black bodies, right? Through racialized capitalism. That has been the priority. And so once there's an understanding of that, once there's an awareness and humility around those kinds of deficits as a result of racism, then I think we can do more work to bringing forward a new generation of providers. But the priority, in my opinion, really has to be in ensuring that there are more providers of color, there are more Black providers that Black consumers can entrust their care to.
Absolutely. We know how important it is to have, folks who look like you and who kind of understand it on that level. So yeah, for sure. Very important points that you made there. Can you describe a little of the historical context of systemic racism and intergenerational impact on Black mothers and families?
I would say, TJ, scientifically, there's research around, epigenetics, and not within, the human trafficking of Black folks through the transatlantic slave trade, but through folks who experienced World War II, either as Holocaust survivors or just individuals in war zones. And while that research around epigenetics and the expression of trauma in the intergenerations or the descendant generations of folks who were in war zones, who were brutalized through the Third Reich, the Nazi regime, we can understand that 246 years of enslavement, we can understand that 100 years of codified dehumanization of Black bodies through Jim Crow laws in America has had an epigenetic effect on how systems have been set up to interact with Black bodies, with Black people, with their stories, with their humanity. The ability to even experience humanity for a Black consumer in health spaces, that has significantly been impacted, not just for, Black folks, but for the individuals who are descendant of human traffickers, right? Who are descendants of lawmakers who codified the dehumanization. What has it meant for individuals coming through and being trained and normalized into brutalizing Black bodies? What has it meant for them? And I think these are some of the questions we have to start asking and have to start moving the lens through which we offer DEI, training and work through. What has happened to those descendants? What has happened to how they experience their own humanity? That did not go away. The brutalization of Black bodies, the priority in Black bodies producing and being a resource of capital gain, that has to be, we have to perceive that through the lens of the individuals who were perpetrating that, right? And these folks are now lawyers, they are policymakers, they are doctors, they are nurses, they are police officers. These individuals are shaping and hold significant power, in our community. And so they are therapists, right? These individuals who are descendant of these practices and who have this normalized into their everyday lives, we have to accept the reality that they were affected too. And that shows up as implicit bias, right? That shows up in the way we do not honor the intuitive knowledge of Black consumers when they come forward, that there is not real education about, what is culturally appropriate for Black folks, especially in the birthing space. I heard, Miss Wanda, in your profound storytelling around Dr. Shalon, you talked about J. Marion Sims, who has been honored as the father of gynecology. I mean, until DEI became a real thing, he was never questioned in the type of research he did during the 19th century, right, on Black women without anesthesia, and the beliefs that he held. And if those were his beliefs, and he is the father of gynecology, if he is the father of reproductive health, then what does that mean of the descendants of his knowledge? What does that mean about their beliefs and their training and how they experience Black women when they're coming in? All of that is transmitted generationally through policy, through practice. All of it is transmitted in that way. So it's not just epigenetically the experiences that Black folks have and the social determinants of health that, we end up experiencing, whether it's high blood pressure, right, which is absolutely, it's a predeterminant to the experience. And sometimes it's not, right, of preeclampsia and eclampsia in the postpartum experience. So yes, there are those ways that intergenerationally Black women who are birthing have been impacted by the trauma of enslavement, through the trauma of being dehumanized and prioritized as breeders, right? As breeders, like that's the narrative that is kind of underpinning the birth experience of Black women. And we don't acknowledge that birthing for 246 years meant breeding. It meant capital gain for America, right? And so how did that disconnect women from their bodies, from their mothering, from what has been natural as far as the birth experience, right? Bringing life forward into the world. So absolutely, epigenetics plays a huge role in that transmission of trauma and what happens to Black women in our bodies when we are birthing, before we are birthing, in utero, right? When children are in utero, they're already experiencing those social determinants of health. What is the mother consuming? What stressors is she enduring? All of that plays out into the outcomes for Black women in their birth experience. But when I think about the intergenerational transmission of trauma, racism, bias, I have to also include what is happening to providers, what has happened to the descendants of individuals who practice brutalization of Black bodies, what happens to the individuals who are being educated in a system that honors gender-variant sins. All of those things play a huge factor into how Black communities, but just the overall community of healthcare, the medical industrial system, have been impacted by the trauma of intergenerational racism.
Absolutely, Tanisha. I couldn't agree more. There's so much there, right, to unpack. There's so much work there even to dig into. And again, all the hard work that we're doing, we are just scratching the surface of these things that need to be done, right? And no matter how hard it feels or how deep it goes, it is still just the surface of all the work that needs to be done. Tanisha, thank you very much for your contribution. And I'm pretty sure that there's going to be questions around, things that you said. So hopefully you can stick around for that. Okay, excellent. We're going to move on to Dr. Alizade. Welcome. Thank you for being with us. And Dr. Ahmed as well, I see that you are there filling in, which is fine. So can you walk us through some of the warning signs of maternal health complications that may occur during the prenatal and postpartum period?
For warning signs to look for during the prenatal, perinatal, and postnatal period, it's difficult because sometimes certain things can be attributed to the pregnancy itself, such as things like swelling or pain or fatigue. So you have to kind of tease that out as a provider, to spend time with the patient to figure out exactly where those symptoms are coming from, what is the onset, what is this degree of severity. And so you need to take a good history from the patient to understand what it is that they're presenting to you. And you need to have time for that. You need to be present for that as a provider. And as far as I'm concerned, and I think many OBGYNs are, especially with the awareness of Black maternal health disparities, that we need to be having a lower threshold of suspicion and be more aggressive in terms of, approaching, patients, because unfairly, sometimes they come in with, health disparities that predispose themselves to other complications, because of which we need to be aggressive in managing them, from the get-go. As soon as they enter the system, we need to try to engage the team, the system, in addressing these things. It's oftentimes that we are there at the end, like catching the baby, for example. I was fortunate that I went to medical school in Philadelphia, so we had a significant Black population that we had patients, and in my medical school class we had Black students as well, and we had mentors. Dr. Albert Reese was a famous maternal fetal medicine perinatologist at the time. And and even through residency, I had a number of Black colleagues, both, from America as well as from overseas. I had interactions with people on a social basis, and then, going into practice too. I worked in Trenton, New Jersey with Capital Health. So again, we had a diverse patient population. And the colleagues that I worked with, there were 6 of us OBGYN hospitalists, and 4 of us were Black and 2 of us were Indian. So we were all minority. So, we would discuss cases with each other. We would advocate for each other. We would advocate for our patients. We were always kind of in that mold. We had a clinic where we saw patients in the antenatal clinic, prenatally, in the hospital. So we had that continuity of care, which I think is crucial. If we can establish that for patients so that they are seen as individuals, and we get to know them and their families and their communities, their support systems. So I was very fortunate to be in an environment where this was second nature to me. Like, it didn't occur to me. I had an idea, and recent news stories, especially, I read about Miss Irving's daughter. That was shocking to me, because it was someone who, it shouldn't happen to anyone. But the fact that she was an educated, highly educated woman, and this happened to her, could happen to anyone, could happen to me, could happen to anyone, was really shocking. And it really shone a light on, that we as healthcare providers are failing. We're not doing enough. We need to do more. And this is intolerable, unacceptable. And these cases need to be examined thoroughly, and at hospital meetings, at organizational meetings. We do at hospitals have a maternal morbidity and mortality review that is closed to the public. And the reason for that is so people can open up, who are involved in the care, to the audience and have suggestions as to what happened, what could have been done differently. And that allows people to open up and speak up, and to develop new systems to address what occurred going forward. So there is that, difficulty as far as trying to study these things, because of patient confidentiality. Hospitals are not willing to provide this information because it may look bad for them or for their providers or things like that. So there's a lot of hurdles to be able to gain the knowledge that you need to gain, the data that you need to gain to address these inequalities in healthcare. And we already discussed the historical, so I'm not going to go into that. But I think that education is important. Marshaling resources is important. For example, in discharge planning, to look out for warning signs, excessive bleeding. If you're soaking more than, 1 or 2 pads an hour, you need to come to the emergency. Don't even bother calling your doctor. Like, as far as I'm concerned, just come into the emergency room, get evaluated, whenever you see an emergency room doc and you tell them you just gave birth, they normally call us right away. They're like, okay, all right, we're going to consult the OBGYN for this because she just gave birth, and they know what to do. So bleeding, excessive bleeding, preeclampsia precautions, headaches, nausea, visual disturbances. These are things that we also discussed during the antenatal period. Like if you have any of these symptoms, you need to let us know. We need to do an evaluation and make sure that everything is okay with the mom and with the baby, because this can also affect the baby, can cause growth restriction, can cause placental dysfunction. And so this is a continuum, So I'm learning a lot of information, and I'm really heartened by the work that is being done, and it's very necessary work. And I think that we're a young organization, and I'm really happy that we're having this discussion, and hopefully in future we can actually have collaborative efforts to have a system for our patients that's multidisciplinary and integrative to support them, preconception, through pregnancy, afterwards. And some of the fault lies in the providers too, that once they deliver, not my problem, like they're fine, but honestly, these conditions of pregnancy do persist during the postpartum period, maybe for several weeks, for several months. They can present, may have had a fine pregnancy, and they may present later. So if somebody comes in having had delivered, they, people may not have a high index of suspicion, which they should. I have personally readmitted people with elevated blood pressure postpartum. They would be on the floor. We would monitor them closely. Sometimes they would need to be in the ICU. So you just have to, do what needs to be done through the objective criteria that you are honed in your training. So if you deal, if you deal in professionalism and, being present as a provider, being empathic, knowing your resources. If I have a difficult case, I get help. I get people to help me. I get nurses to help me. I get other providers to help me, even people in other specialties to help me. If I have I had a patient who was suspicious for appendicitis. I had to advocate for the general surgeon to take her to the OR. So sometimes we even have to be advocates to, please, I know she's pregnant, but honestly, I'm giving you clearance. You need to do what you need to do, So sometimes other specialties are a little bit, a little bit leery of dealing with pregnant patients because because they have to deal, they have to understand the level of risk to the fetus. But so that's why we're here as a consultant to, help provide that support to them. So it's complex. It's a complex system that we're in healthcare, and we're like little cogs in the wheel, but we try to do the best we can in the situation that we find ourselves in. So mainly education, mainly giving precautions to women, especially at the time of discharge from the hospital, when to come back, when to call your provider. Don't minimize, take things seriously. Have a blood pressure cuff at home if you need. Have a pulse ox at home if you need. Things of that nature to gather data for yourself. Call your doctor and be like, I checked my pressure and it's a bit high. I'm a bit concerned. And you should be evaluated. So there are things that can be done, simple interventions that we can do to help, improve morbidity and mortality for patients.
Thank you very much. I would have follow-up questions, but you answered all of them. You did a very good job of going through all that. That's very much a lot of important information there.
Oh, I didn't even go through like the medical, categories of what, like the main causes of. So can I just do that real quick?
Absolutely.
So things that we really look out for as obstetricians, because we're into catastrophic things, we need to know how to manage. So hemorrhage, bleeding, any kind of, miscarriage, ectopic pregnancy, management, pregnancy, placental problems. Those are a category of maternal morbidity and mortality. Postpartum depression, where, there could be self-harm, suicidal ideation, psychosis, a harm to the child, infection, sepsis, endometritis where the uterus is infected, or chorioamnionitis where the fluid around the baby is infected, and you have to decide whether to deliver or not to deliver, indicated preterm delivery. Hypertensive disorders, we touched on this, very, very, very catastrophic if missed, can cause strokes, heart attack, death. And so this is something that we need to be aggressive about. Blood clot complications, blood clot in the leg that can travel to the lung, cause pulmonary embolism. So venous thromboembolic events. So these are like big categories of things. They can be up to 30%, 20% of maternal morbidity and mortality. So these are things that women need to be educated on, look out for warning signs of, lightheaded and dizziness, passing out, signs of like volume depletion, dehydration, things of that nature. So education is very, very key to be able to look out for these sort of warning signs.
Absolutely. Thank you very much, Dr. I appreciate that. A lot of information. I mean, we've had a lot of information given to us today. We had a lot of important things to discuss. I wish this panel could be like 4 hours long, right? Because these things really can be discussed for a very, very long time, right? Like this is just like the tip of it all. So with that being said, I do want to get to because I'm looking at the time and we are getting close to the end here. So I do want to get into some of the questions and answers that we have, or some of the questions that we have for answers. So I'm going to jump into that and we're going to see what we have here. So I'll start with a question that we have here for Tanisha. How can we encourage and empower Black and Brown mothers and birthing people to practice self-advocacy and the prenatal period, and a system that's often fails to provide the time and space to listen to patients?
Not being listened to or not feeling heard is something that often comes up in the sessions that I have with women experiencing depression, anxiety, and PTSD. While I'm a marriage and family therapist, my primary training is as a narrative therapist. And so one of the ways that I go about that for folks who have connected to mental health care through Black Women's Wellness Co. is supporting them in telling their stories compassionately to themselves, right? Rooting out some of those distorted thoughts that dehumanize themselves, right? And so teaching women how to tell their stories by first feeling compassion for themselves and understanding that what they're experiencing is valid, right? That that what they're experiencing has value and that it should be heard, and that the issue is external to them, right? Because so much of the social experience has been silencing to Black women. And so there aren't really a lot of skill sets in telling stories. And so I think a lot of mental health care has to be offered, but also emotional health care, because there's a lot of shame in telling the story, right? Not wanting to be seen as an angry Black woman when you are trying to advocate for yourself, when you're going back and forth to the hospital 5 times because you're feeling something, but you're being told that it's not real, that you're fine. But intuitively, right, teaching women in that compassionate storytelling to also connect to their intuitive knowledge, that is critical. And so while, I do that through therapeutic relationship, other ways that can be done and that I've offered my services to is through, programming very early on in high school, elementary schools, right? Teaching young folks how to storytell, how to talk about themselves in a compassionate light. And that has to start very early on when I'm doing family therapy, right? Supporting parents and being able to hear their children, right? Because that's where it starts for a lot of Black folks. Children being seen and not heard is we have such a long history of that being the rule of safety. If my child is not seen, then they can't be harmed. And so very early on, Black and Brown children are silenced. We don't have the skills to tell our stories. And so, just teaching compassion and storytelling and as parents, as caregivers, as providers, creating space and room for that. And also that connection to intuitive knowledge, that what you feel is also information that's just as valuable as the cognitive knowledge, right? Your thought knowledge that's coming in, and being able to bring those two things together and express it in a way that feels compassionate, that feels, it helps them to feel confident, but also as a human being, like helps them to feel human, that I'm a real person in the world. There's a lot of dissociation for Black women, for Black mothers. Like, why are people not listening to me? Am I crazy? What's going on? Right. So really starting from those places, that's how I've done it. But I think that the work that Ms. Wanda is doing, that Ladina is doing and has been doing, that Dr. Harris is doing, even over here with Dr. Alizade and Dr. Ahmed, that you all are doing. These are all spaces, but the collaboration amongst these spaces as well is really important in developing those skills for storytelling and creating space for compassionate storytelling as well.
Absolutely. And that the last point that you had there about the collaboration is, I think that's really key. The more these kind of systems come together and people start to work together as a unit, and understanding that, like, you know, in these silos, and we're doing work in these silos, that's not going to be productive, and it's not going to get us to where we need to be. It may be a little bit helpful, but it's not going to get us all the way to where we need to be until we start coming together. So thank you for that. Our next question is for Wanda. First, I want to thank you for sharing your story once again, and deepest condolences to you and your family. The question that was posted by one of the viewers, they were wondering if the doctor was held responsible for your daughter's passing.
No, he was not held responsible, and not many of them are. There are so many obstacles and challenges placed in your path when you're trying to get them held responsible. And it's like the circling of the white coats, more or less. And so, no, they get away with it time and time again.
Unfortunately, and that's a common part of the story, right?
Yes.
Yeah. Thank you again. So our next question is for Ladina. Any thoughts on how to get more BIPOC clinicians in the field? With such a workforce shortage, how can we attract more BIPOC clinicians? So recently, a professional in the field reported that approximately 57% of those obtaining a master's in social work don't go for their license due to the cost and lack of resources and time that's needed.
So I don't know that I have the answer, TJ, but I think, you know, in short, you know, creating a more culturally inclusive workplace, right? And ensuring that, you know, when individuals, you know, are coming in, Black BIPOC are coming in, and interviewing, that you know, we're providing a space that represents them in some way. There's some sort of representation, right? I think also recruiting in the communities and in those universities. You know, we spoke of HBCUs, you know, even before that, you know, going into the community, possibly, you know, having some of these discussions with the younger generations, right? So starting, you know, when they're young, you know, and showing them, you know, what the possibilities are, you know, and showing them what this field can offer and what they can offer, you know, in this field as a mental health professional. Again, there's probably so much more that we could be doing, but I think that, you know, reaching out to the community, Another thought that just came up is, providing funding and opportunities, right? Because it's mentioned, the lack of resources, the lack of funding, so providing, more funding for Black and Brown people to be able to afford the education necessary to enter this field as a professional. Those are just some thoughts that I have. I'm sure that others may have other thoughts as to, how we could increase the workforce. But again, I think we just have to keep these conversations going and get out there and recruit and provide the necessary supports and resources.
Absolutely. Thank you very much for that. And as people of color who are in this field, right? As Black men and women in this field, it's definitely something that's always on our minds, right? It's definitely something that we're talking about and thinking about, and how can we recruit more people, to be in the field, because we know how important that representation is, for sure. So thank you very much for that, Ladina. And our last question here is for Dr. Ahmed. Are there any specialized prenatal screening tests or diagnostic tools recommended for Black women to identify potential health risks early in pregnancy, and kind of like tailor any intervention accordingly?
I think that, for example, let's take preeclampsia as a potential thing that we should consider screening. There have been some tests that have come out, but I'm not sure if they have become mainstream yet. To look for markers, I wrote them down. The mean arterial pressure, the mean uterine artery resistance, and something called PIGF, like a combination of factors, which is high sensitivity for preterm preeclampsia before 34 weeks. There's something called an SFLT1 PIGF ratio. There's something called a PIGF level. So there are things in the works to help screen for example, preeclampsia. For someone who has had it before, they're at increased risk for recurrence. So for those women, definitely early prenatal care as soon as they find out they're pregnant, and early maternal fetal medicine consult would be a good idea. In addition to that, intervention simple as baby aspirin has been found to reduce the risk of recurrence risk of preeclampsia, or if it occurs, is not as severe or is not as early onset. And we think it works because it inhibits platelet activation, which is part of the endothelial dysfunction that is one of the etiologies of preeclampsia. So there's endothelial dysfunction, there's vasospasm, it affects the entire body as well as the placenta and the growth of the baby. So, and it's a systemic disease. We don't know what causes it. There are risk factors such as young maternal age or advanced maternal age, or a history of preeclampsia, or sometimes a new partner can have a risk of that happening. So I think that one of the things we were addressing is something called chronic stress, which is definitely pervasive, but especially with the racism in the society, with the effects on the Black community. So, and I come from a functional medicine perspective. So when an individual undergoes chronic stress, it causes inflammation in the body. So things do not function the way they should in terms of promoting health and healing. And they often go towards the direction of ill health, such as high blood pressure or uncontrolled blood sugars, and other sequelae that can occur if these things are not put in check. So stress reduction and stress management is important. Stress is not a bad thing. Stress is needed maybe 5 or 10% in your life, like when you're running from a lion or something like that. It's not needed in the 90% of life that we're generally living in, where we're afraid our boss has implicit bias or that kind of thing. Like each day is like walking on eggshells, that kind of thing. So these are the issues that we need to address as a society, the systemic issues that are causing this chronic stress epidemic, chronic inflammation epidemic, which then has sequelae in chronic disease that we've spending billions of dollars in this country in the healthcare field, and the loss of GDP, frankly. There's absenteeism at work because of problems that people are experiencing. So and then we were talking about epigenetics, about trauma, and there was a study that just came out 4 days ago about how people who have experienced adverse childhood experiences, or what's called ACEs, when they had muscle biopsies done, it was found that they had mitochondrial dysfunction in their muscle later on in life, even in controlling for other factors. So it goes to show you what happens when someone is under chronic stress or PTSD. It affects their body's ability to function physiologically to the point where their mitochondria, which are the energy producing factories of the body, are not doing their job and causing muscle wasting or sarcopenia, loss of muscle. And we know how important muscle is because that is our energy factories. That's what keeps our metabolism running. If our metabolism isn't good, we have problems with weight gain, with diabetes, with insulin resistance, and problems of that nature. So health is a continuum. It starts from the womb, just like we were discussing, what the mother ate, what the father is eating. I just found a study, now this is in mice, but they found that, the mice that ate a high carb diet, their sons, the mice sons, would have increased anxiety. And if the father mouse ate a lot of fat, the daughter mice had a lot of fat deposition on their bodies. So even fathers, the paternal background is important when it comes to child health. So all of these things are related: trauma, stress, diet, nutrition, lifestyle. And so, from a functional medicine perspective, that's like, exciting that we are finally acknowledging, these issues, the food supply, the water supply, lead paint, contamination, environmental injustice, these sorts of things need to be addressed at the governmental level. Like, there's not something that we can do alone. We have to address the corporations, that are, feeding off of this ill health in this country. So it has to be done at the governmental level, but unfortunately, a lot of our government is captured by corporations. They have a tremendous amount of power to not do the right thing, and it's been going on for hundreds of years. So it's an uphill battle, but the main thing is to get the data. We're doing studies, we're doing research, we're gaining data, we're having evidence. And people listen to evidence. It's not just about, well, I feel. No, we have numbers, we have evidence, and we can show lawmakers that, look, this is what's happening. We need to address this problem. So the more data we gather, the more we advocate about these issues, the more we'll get a response and more funding to address them.
Absolutely. I mean, all remarkable points that you made. And one of the last things you said there is about it being a multi-level approach, right? Like, there's many different prongs here that have to be acting on these things in order for real change to happen. So thank you very much for that. I want to thank you all so much for being here. I want to thank our panelists for being here, for your insight and your transparency. The questions and feedback were phenomenal. I would like to thank all of our guests for being a part of the discussion once again, and thank everyone for asking the questions and going on to be most impactful as you are in supporting the Black maternal health, pregnant persons and postpartum persons, and navigating your own journeys. Again, thank you. I cannot thank you enough for joining us. I do want to take the time to acknowledge some of the people who are involved in this and some of the programs that we've mentioned throughout. So it was made possible in a partnership with Dr. Shalon's Maternal Action Project, the Maternal and Child Health Black Women's Imperative, the Black Women's Wellness Co., and All Health Medical Group, Care Plus New Jersey, and the Maternal and Family Center, as well as our IDEA committee. So again, thank you all so very much. Wanda, you had your hand up. You had a question?
I didn't have a question. I wanted to share a quote that I came across that I thought would be really nice for ending, if that's okay.
Absolutely.
It was by Arundhati Roy, and I know the pandemic is a little bit past now, but historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it. And I just added, it's time for us to reimagine maternal health care and fight for it.
It's a wonderful way to end. Thank you very much for sharing that. We really appreciate it. On the screen now, you can see some of the panelists' contact information for those you may want to reach out to and get some more info. I'm pretty sure everyone had a lot more to say. Because again, 2 hours does not cover all that can be said on this topic, but we are just getting started, right? We're just scratching the surface of it all and getting the work done. So again, thank you all for being here. Thank you all for showing up. Thank all our panelists, all our guests, all the people that help make this happen, all our folks in the background helping keep this thing running. Appreciate you all as well. Thanks again for being here.